as well as imaging. The change is this change the result from recognition that the surgery is not considered this is because, as we know, that surgery it is not curative and have high risk of related the complication to the complication. So usually we don't need to go for surgery for all patients. History and physical examination is essential for diagnosis of endometriosis. More than a lot of studies, one was reviewing more than 5,000 patients with endometriosis, and they found that chronic dysmenorrhea, dyspareunia, postcoital bleeding, and abdominal pelvic pain, menorrhagia is one of the presenting symptoms, as well as infertility. How can we diagnose? Pelvic examination is one of the important things that I'm sure that most of us they don't perform it for the patient, although it can reflect a finding and it will help us in diagnose the case, especially if we have endometrioma or there is nodules at the posterior vaginal fornix, especially in deep infiltrating endometriosis. And during examination too, we can visualize the lesion in the speculum if the lesion is invading the vaginal area. A clinical examination has low accuracy, as a normal finding usually doesn't reflect the absence of the disease. So especially if we have a superficial or peritoneal endometriosis. Imaging is important modality for non-surgical diagnosis. The transvaginal ultrasound is the first line investigation for suspecting endometriosis. It can be used to diagnose endometrioma, and it is helpful to rule out any other pelvic pathology. Advanced transvaginal ultrasound, even with the expert people, with the expert gynecologist or radiologist, can detect even deep infiltrating endometriosis. And usually it's not routinely available. So because of that, we have to look for other tools will help us to diagnose endometriosis. MRI can be used with deep infiltrating endometriosis. It has a high sensitivity and specificity. So both modalities are excellent in detecting adenomyosis, especially in the case of severe dysmenorrhea. No imaging can be reliable to detect the superficial endometriosis. So usually we may base on the symptoms in treating the patient. The definitive diagnosis can be made only by surgery, but as I mentioned previously, current guidelines recommend against performing laparoscopy only for diagnosis. Current recommendation provide a clinical diagnosis based on the symptoms, signs, and image without need for the surgery, as I mentioned. Providing the treatment on the base of the clinical diagnosis reduce the delay in treatment of the patient and can decrease the likelihood of long-term sequences regarding the complication that may happen with the endometriosis. We recommend the treatment should be started based on the clinical diagnosis. Treatment of endometriosis, usually we have the surgical, medical, surgical, or combination. But before the treatment, each patient we should go in details, as I mentioned, regarding the history and physical examination to exclude other causes of a pelvic pain. Option of the treatment of the patient with the symptomatic endometriosis are medical, surgical, and combination, as I mentioned. Endometriosis now is regarded as a chronic disease with a very high recurrency rate. It should be managed with a treatment plan and cover the entire reproductive lifespan of the patient and aim to increase the effectiveness and the duration of medical suppression of the disease and limit the frequent and extent of the surgical intervention. So this statement is very important in treating endometriosis. That means not every patient we have to take them for surgery as the our first line of management. Medical option that is available in Saudi Arabia, we have a non-steroidal anti-inflammatory drug, combined estrogen progesterone hormonal therapy, progesterone only option, GnRH agonist, and aromatase inhibitor. The medical treatment option should be decided on the case by case. So not every patient should have the same management. So the decision based on the case that we are, or the presentation of the disease, keeping in our consideration the nature and the severity of the symptom, if the patient having a pelvic pain, infertility, or adnexal mass, the distribution and the location of the endometriotic foci, demographic characteristic of the patient, and the preference and the side effect of that medication itself. And if the patient is thinking about to get pregnant, this is one of the things that we have to think about the options of the medical management. As the current body literature lacks a clear data favoring one treatment over other, choosing of the medical option should be shared decision between the physician and the patient. Non-steroidal anti-inflammatory drug, it's helpful in treatment of primary dysmenorrhea, and it should be used as the first-line option in the treatment of endometriosis pain, alone or with other hormonal therapy. Combined hormonal therapy, widely considered to be the first line as a management as a hormonal therapy. And it has a highly efficacy in reducing the endometriosis pain and improve the quality of life. Especially that most of the side effect can be, most of our patients can tolerate the side effect, and most of them, they may have less side effect with the time. A medical evidence enabled so far favorable, as I mentioned, is like we don't favor one medication over other. The decision depend on the experience of the physician and their patient, and it should always be a combination of medication of non-steroidal with other medication. And we have many formula or of combined hormonal therapy, including either pill, transdermal patch, or vaginal ring. The hormonal therapy, it could be either used as a cyclic or continuous back-to-back fashion. Both has a good result with endometriosis in reducing the symptoms and improving the pain. But systemic review and one prospective study showed that the superiority of the back-to-back or the continuous treatment or fashion treatment on the cyclic progesterone. Progesterone only. It can be safe, effective alternative for the patient who are unable or do not prefer to have a combined contraception. This including oral options such as norethindrone acetate, Dinogest. It could be injectable, such as a hydroxyprogesterone acetate, subdermal implant like Implanon or etinogestrel implant, and levonorgestrel intrauterine device, which is the Mirena. The efficacy of the different progesterone was evaluated in Cochrane review and systemic review, focusing on Dinogest, which is the Visan, everyone know it by this name, and they found that a continuous progesterone have a good effective in treatment of endometriosis pain, and no evidence that one oral progesterone is better than other. They found that the continuous progesterone are effective treatment, and systemic review comparing the levonorgestrel releasing intrauterine hormone and gonadotropin, which is GnRH agonist, and both have a similar effect in improving the pain of endometriosis. GnRH agonist considered to be a second-line therapy of the endometriosis-related symptoms. A meta-analysis published in 2010 and include more than 5,000 patients and shows that GnRH agonists were effective in management of endometriosis pain. Add-back therapy is one of the important things that we have to do if we are considering to use a GnRH hormone, and this will help us to improve the symptoms associated with GnRH, which is vaginal dryness, hot flashes, and bone mineral density effectiveness. And the things that we have to start both backup therapy with the GnRH at the same time. No need to delay the GnRH because many studies shows that the add-back therapy will not affect the result or the mechanism of the GnRH agonist. Aromatase inhibitor could be utilized as a last resort. It could be used as alone or combined with other hormonal option like a combined hormonal therapy or GnRH and progestin. Choice of the hormonal treatment. So for the patient with the endometriosis-related pain, it is recommended to prescribe non-steroidal with a continuous combined hormonal contraceptive or oral progesterone option. The efficacy of the treatment should be assessed after 3 to 4 month duration, and if it is found that it is adequate and effective, the treatment can be continued until the patient express the desire of getting pregnant or she reached to the menopausal period. In case of inadequate response, non-steroidal should be continued, and alternative combined contraception or progesterone option should be prescribed, including subdermal implant like etonogestrel and the hormonal intrauterine device. Due to their concerning significant side effect profile, GnRH agonist and aromatase inhibitor should be preserved for the patient who have failed the first line treatment of the management. And at that time, we have to go back to and give a GnRH agonist, or if the patient suffering from the severe symptoms, that it will not be improved unless GnRH will be given. Surgical treatment of the endometriosis. The option of surgical management, it could be either conservative or definitive. Surgical treatment is used when the medical therapy are contraindicated, especially for the patient who are trying to conceive, not tolerating or having a failed medication. Minimal invasive approach with the complete treatment is the standard of care, international standard of care of managing endometriosis cases. Some patients may choose a surgery as a first option after counseling both benefit, including fertility benefit, and its risk, including the recurrent and the persist of the pain from other causes. Sorry. If the patient with the endometriosis that may involve ureter or bowel obstruction, surgery usually is the only management option for those cases. If the surgical management is done, endometriosis should be staged according to the American Society for Reproductive Medicine classification system from minimal to mild, moderate, or severe, which is the four staging. This system reflects only the extent of the disease, but it will never reflect the severity of the pain or even the impact on the fertility. Endometriosis, surgery for the superficial peritoneal endometriosis or endometrioma may improve the chance of the nature contraception, but must be balanced with the assisted reproductive technology. Cohort review conclude that the surgery was effective for pain symptoms with the following 6 to 12 months, and other reviews that the recurrency rate will be it will happen about up to 20% after 2 years and up to 40 to 50% after 5 years. Treating the patient with the hormonal post-op, it may help to decrease the rate of recurrency. Because of the complexity of the associated with the surgery for the patient with the deep endometriosis, knowing the extent of the disease by reviewing the imaging will help us to decide how extent we can go and treat the patient during the surgery, and will help us to improve the symptoms of the patient of the surgery, because usually the first surgery is the best surgery for the patient regarding endometriosis. Surgical treatment of endometriosis by eradication of the endometriotic lesion. As a part of the management of endometriosis, it could be by either excision, electrosurgery catheterization, which is ablation, or laser ablation. Surgical intervention had advantage of providing a histopathology confirmation of the diagnosis, exclude any malignancy, especially in the adnexia lesion, with the concerning feature if we're thinking about malignancy in the ovary, and the pain reduction by eliminating the endometriotic lesion. It should be offered the patient who had a poor or no response to the medical treatment. It should be offered for those who are not responding to the medical treatment or who are refusing to go for medical or have a contraindication to receive any hormonal therapy, or if the symptoms is involving, as I mentioned previously, any urinary or bowel symptoms. Conservative surgical intervention involve excision and ablation, as I mentioned, and it shows that both have a good result of improving the symptoms. It should be considered as a conservative. It should be considered as a first-line option in the majority of the women who are considered for surgical management, and because it is less invasive, associated with less surgical morbidity, and preserve the hormonal and reproductive capability of the patient, especially who are planning to get pregnant in the future. It has associated with high rate of pain recurrency and need for re-intervention again, comparing to definitive management. Patient who underwent laparoscopic excision, or they were comparing both excision and hysterectomy, they found out after following up by 8 years, it shows that the reoperation rate was about 35% for those who went for conservative management, comparing to 5% who underwent hysterectomy. Surgeon could either be excise or ablate the endometriotic lesion. The result currently available in randomized controlled trial and systemic review comparing those methods are inconclusive. Despite the contraindication, we recommend excision whenever visible, as it is more suitable with the deep infiltration endometriosis, providing a tissue histopathology confirmation, and when done properly, it avoids the thermal spread to the adjacent organs such as bowel, blood vessels, and ureter. Laparoscopic hysterectomy as a definitive management with or without ovaries is also an option for a selected patient, such as those who are undergoing severely dysmenorrhea, having heavy menstrual cycle, or with the adenomyosis of the disease and who does not desire to get pregnant anymore, so we can counsel them regarding the definitive management. Hysterectomy with the treatment of its better pain outcome comparing to conservative surgery. Removal of both ovary causes a premature menopause with a potential adverse effect on the bone and heart, and provide only marginal additional benefit of the pain improving over the hysterectomy alone. The study revealed that the hysterectomy with unilateral salpingo-oophorectomy offered a mid-ground solution for the young ladies undergo definitive surgical management for pelvic endometriosis. The benefit of lowering the risk of recurrency should be carefully balanced against the risk of surgical menopause in the young patient, especially if we are operating on the patient who are young or their age is less than 45. So we recommend that hysterectomy should be only offered for the patient who does not wish to conceive and have severe endometriosis symptoms. And hysterectomy could be offered with the patient who are additional indications such as symptoms of uterine fibroid, or endometrial hyperplasia. During the conduction of the definitive surgical treatment, we recommend that to ablate or excise any endometriotic lesion, so it will help us to reduce the risk of recurrency or recurrent symptoms. Bowel endometriosis, it's if we have the disease invading the bowel, reaching up to the muscle, not only the superficial periton, which considered to be a peritoneal endometriosis. If it is invading the bowel, at that time we have to diagnose them with the bowel endometriosis. It affects about 25% of the patient, and most of the lesion will be in the rectosigmoid segment. Surgical management lesion is indicated when the patient presents with the significant pain, sexual, bowel, or infertility. Surgical techniques such as resection, discoid, rectal shaving have been utilized for management of such lesion. We recommend that more conservative approach, which is the shaving or discoid excision, should be first-line option of should be offered to the patient, as it have a good result, as well as the resection, and usually this will reduce the risk of having a leaking or even fistula. In patients with the persist pain, multidisciplinary plan of care must likely lead to improve the quality of life. This may include pain education, pelvic physiotherapy, psychologist intervention, and targeting the interventional for other pain multidisciplinary patient-centered approach has been recognized as the best practice for chronic pain condition. So in conclusion, endometriosis is a common condition that can lead to chronic pelvic pain, infertility, and organ damage. Early recognition will help us to start early treatment and prevent the future complication. Care providers should make the clinical diagnosis of endometriosis and start first-line medical management as soon as possible. Refer to specialized gynecology for the second-line hormonal therapy. Surgery is important when indicated, and hormonal or surgical management can provide a symptom relief and part of the long management plan. Multidisciplinary care may be required to treat the persist pain. Thank you, everyone. And those are the team who were working and preparing those guideline, and inshallah it will be released soon, and it is under the process and it will be released soon.
Thank you very much, Dr. Areem, for your interesting lecture. And I'd like to thank Dr. Naeem Al-Shanqiti. She's sharing us with the Saudi guideline and all the team who's doing the Saudi guidelines. We are going to put the video, but because Prof. Fernandez is going to leave, so I have one question or two to Prof, and if anybody want to share. Do you think after implementation of saliva test, any study shows how much it's going to be reduced for the time for diagnosis for endometriosis?
In my opinion, there are two main interests: to decrease the delay to have a diagnosis, but also to understand that we use the test not como a screening test, but like a diagnostic test. This is very important to understand, because we must avoid to use for all the patients with pain this test. At this moment, we begin a study in France to understand if we can decrease also the rate of surgery, of laparoscopic diagnosis to have the diagnosis of endometriosis. This is very important because in France, we estimate between 30 to 50,000 diagnostic laparoscopy for endometriosis. So if we can decrease this rate of surgery, it will be very interesting for the woman. It's very, very interesting for the health cost, and probably we observe to decrease the morbidity of surgery.
Professor, the question is it decreasing the time for diagnosis? Today we are seeing that we have between 8 and 12 years to diagnose the endometriosis? Is the test will the time?
Yes, I understand. I can explain more. Probably when you have a woman with a pain, we can propose sonography, we can propose MRI. If the diagnosis is easy with the image, there is no problem, there is no indication of test. But probably the majority of patients have pain without specific image. In this case, probably we go to begin by a treatment, by hormonal treatment. In France, we use in the majority of cases progestative and dynogest because the other progestative are forbidden at this moment in France. And when we see again the patient after 3 or 6 months of treatment, if the pain has disappeared, there is no indication, and we continue the same treatment. But if the pain continue, at this moment, we can propose the test. And if we observe this new algorithm, obviously the time to have the diagnosis will not be 7 years, but will be for all the patients less than 1 year, only the time to test a first treatment against pain, hormonal or non-hormonal treatment. And if the pain persists, you can propose a test, and obviously you can share the patient with a disease or with other disease than endometriosis.
While we are keep asking the questions, there are actually the video films for sample collection. It's appearing, so you can watch, and we are keep asking the questions. Another question that for you, Prof. What are the countries where saliva test was applied?
I'm sorry, I don't understand.
I
Or
can
Lina can answer.
Yeah, I can answer that question. We are present in Germany, UK, Switzerland, soon in France with the reimbursement, and we are in Hungary, in many other European countries. We are in of course in Saudi Arabia and UAE, Kuwait, and many others coming now. Canada, it's in the plan. Australia in the plan for the coming year, for 2025. FDA is under process to go and launch it in US.
Yes.
Can you estimate the total number, how many tests was done worldwide, approximately?
I don't have it in mind, but it sure, I mean, thousands of tests, 100,000 of tests. It depends on the country.
I want to leave the floor for Dr. Naima if she want to ask questions, or Dr. Arim or Osama, or otherwise I'll proceed. So Naima, do you like to ask any questions?
Yeah, just I want to ask about the cost effectiveness compared with laparoscopy. There is any studies regarding this, Dr. Zoe? Prof? Do you have any studies regarding the cost effectiveness regarding the comparing the sensitivity of diagnosis between laparoscopy and the saliva test?
In France, we do an economic evaluation, and we observe that with the price of the test around 700 or 800 euro, it will be cost effective when we compare with the strategy until the use of salivary test. Because the cost of surgery, the cost of MRI, the cost of multiple consultations is too high, and it's always higher that you very early a test after 6 months of medical treatment, if this medical treatment is a failure. We don't see immediately the cost. We must evaluate the cost of the test with the history of the normal diagnosis, with the delay of diagnosis until the use of this test.
Dear Dr. Samir and Prof, and thank you, Dr. Naima, for raising this question. So there is a direct cost, which is as highlighted elegantly by Prof. Fernandez. However, there is an indirect cost by the quality of life of the patient. So it has to be a mathematical model to show the impact of incorporating this test in the clinical practice, which I believe it will be substantially significant.
Thank you very much for this clarification. This is what I want to hear, that collectively what's going to be the impact of starting using this method of method of diagnosis. Thank you very much.
Though I am a surgeon, but for me, because I like to do laparoscopy, and the same for Dr. Arim and for surgeons. And laparoscopy is invasive procedure, while this one is non-invasive procedure. But however, I think it will be additional for lifestyle, for diagnosis, and for all our ladies in Saudi Arabia. Yes, Dr. Arim.
Yeah. Okay. So regarding this test, I'm sure it's like they explain it very very clear for the audience and for the physician who are attending the webinar, that the test should not be performed for all patients. So once the patient is diagnosed by symptoms, by imaging, I don't think we need to go for the test. This is for who is having a chronic pelvic pain, and we are suspecting all the investigation and the clinical diagnosis showed no endometriosis sign, and we are still suspecting there is endometriosis. This is the time that we can do the test. Am I right, Osama?
Yes, absolutely. You are correct. This is the current evidence suggesting that, and this is the current recommendation from the manufacturer. And add to that, if there is unexplained fertility. So there is a huge component of patients who visiting IVF clinics seeking to have an offspring. I think those people should be exposed to this smart solution.
Thank you very much for your clarification. I think this is very important. It should not be misused, and it should be for certain patients according to their symptoms and according to radiological investigation and for unexplained infertility. And I think it's a beauty that now we have the Saudi guidelines, which is ready and going to be submitted to MOH to be approved from MOH.
Inshallah. Inshallah, it's going to be soon, inshallah.
Inshallah.
I truly appreciate the collective effort, and when Dr. Reem elegantly mentioned the guidelines in the final slides, I appreciate it's from different regions, the expert in the field of gynecology. So wish you the best of luck, and thank you for adding to our community such scientific guidelines.
Thank you. Anything you want to add or anything? So when we suspect it, Osama, after 2 weeks, it will be ready in Habib?
Indeed, yes. We already did some sort of preliminary logistic examination. We're on the final stage in validation, the logistic issue. So I expected in the next week, beginning of next week on Monday, the first sample should be collected, 11/11, and within after 2 weeks, I think you will have the positive result. 10 days, you will have the positive result to start collecting the samples in all Dr. Salman Habib hubs.
Thank you. Before we are leaving, I want to remind you that everybody that welcome to our 6 OD OB-GYN, which is going to be in Crown Plaza Digital City, and we have the 4 workshop. So welcome to join us. And I want to remind the people who are born in March to send to Marwa. So Tim going to be selected to attend the conference or to attend the 2 workshop, which is ovulation induction and placenta. So welcome. It's a gift from Zurich, and we are ready to help you anytime. It's our pleasure to be there and there. I leave for comment from each party speaker if you want to say anything. I'll start with ladies first. So Dr. Naima first, Dr. Naima, and then Dr. Rima.
Okay, Dr. Samir, thank you very much. And I'm gonna thank all our distinguished speakers, and our audience, and the ZWIG lab for this innovation, which can make a new era for development of enhancing the diagnosis of this complex disease, which all obstetrician gynecologists, the most difficult thing to manage, it is endometriosis. And from Ministry of Health, first of all, we, as a collaboration with our colleague, we went to adapt or to release the Saudi guidelines as the first step, and also to invest in any technology will enhance the women's health. Thank you very much.
Thank you very much. Dr. Rima.
Okay, thank you so much for the great effort, Dr. Samir, Dr. Naima. Thank you for the support regarding the Saudi guideline. And I'm sure that it will help a lot of physicians to know what to do with these cases and how can they refer the cases to the expert people. This test is great. I think it will play a big role in diagnosing endometriosis. And having this webinar from time to time will help us to just refresh the physician and to increase the awareness between them regarding endometriosis. Thank you.
Thank you. Osama and Lena, or Lena first. Lena, ladies first.
Okay. I just want to say that we believe in what Saudi Arabia is doing for women's health, and we do believe that this is a start for very big innovation in the coming years. And I'm here to say that I'm very open, especially with the top people that we are having on this webinar and in Saudi Arabia generally. I'm open to. We are conducting many studies regarding the phenotypes, the cancer with the microRNA, and I think Saudi Arabia should be part of this because Saudi Arabia is a reference country for many countries surrounding and more than that. And I think it would be great to have this implemented in Saudi with other countries like Europe and US. I hope that this will be a kind of start for something else in the future.
I think it's clear now that our country are going directing the health service towards women. Sulaiman Al Habib, they opened the center which they call them Women Health. They have which is in تخصصي. We have a program for women health. National Guard soon, they are all going to open for women health in National Guard Hospital in King Abdulaziz in Riyadh. So the country, they are looking for their health. Those women are our sisters, our mother, our daughters. So we are going to take care of them more than we are taking care of ourselves. It's a beauty that you have a woman in your life. I leave to Osama if you want to say anything.
Yeah, indeed, Dr. Samir, I cannot agree more than you for your final statement. However, I have a modest suggestion. In case there's a couple of those 10 winners are not interested in attending the conference for reason or another, I think they might dedicate to do the test to one of their patient, relative, or themselves. This is a modest suggestion. And finally, truly, it is my pleasure to be today with the gynecology community. Thank you for having me, and wishing you the best of prospective positive impact in our community. Thank you so much.
I'm sure now you love women more than me, and you. Inshallah, I'll leave it to Lena if you want to have any comment.
I would like to thank you all for everything you are doing for the women health and for the week. Thank you very much for this webinar. Thank you, Dr. Samir, for organizing this, and a pleasure to meet you soon in the conference of November, end of the month. Thank you very much, and a lot of success for Dr. Osama in this launch of the week on the test.
Thank you.
Thank you very much.
Thank you very much.
Thank
Bye.
you.
Bye bye.